Buon pomeriggio e grazie per la vostra.
Good afternoon, and thank you for being here at this meeting that takes place at the 40th anniversary of our law, the law that created the Italian National Health Service. The title of this meeting is Medicine for the People, Challenges for the Future. This title wants to state somehow the need for our country to a health system that can provide medicine for the people. Furthermore, this title underlines the urgency to take decisions today in order to efficiently face the issues of our national health system. The objective is to make this system improve as a service to the people without being limited to a simple market sector. So there was, this law which was issued in 1978 that created the National Health System. It was issued on the 23rd of December 1978. This service, and I quote from Article 1, this service is made up by a series of structures, of services and activities aimed at promoting, recovering and maintaining the physical and psychological health of the population. So I'll stop here with the quote because then we will have time to think about this. But what is most important is that this service includes both health and medical aspects, but also social aspects. As we all know from personal experience, that there are some social aspects which are fundamental in terms of human health. It has also to be noted that this service is made up of the activities carried out by so many different actors. They are all different, but they all serve the same purpose. There has to be this common goal and a common way to pursue this goal. And this is what creates a public service for public health. In the last 40 years, the developments for the National Health Service in Italy have not been has not been as smooth as everybody knows in Italy. There have been situations and evaluations at the international level that identified our services as one of the best national health services. Other evaluation criteria, on the contrary, did not acknowledge the results of our service. And so many other outcomes were actually obtained in many different fields connected with human health. But there have also been a lot of scandals that actually jeopardize this service. The quality of our national health system has often been acknowledged, but apart from sensationalism, there have been many protests on the part of citizens, of the users of this service. And today, the most critical issue is the sustainability, the economic sustainability of the health service, even though this does not cover all the problems, because there are also some cultural as well as social and political conditions that can influence the future of this service to the people and service to the communities. Today, in order to have an experienced voice that will talk about this service, its value, its crisis, and the necessary choices that have to be made in order to develop this and improve this service, we have a very distinguished panel, and we have speakers who have been dealing with these themes for quite a long time, playing paramount roles in educational, scientific, social, and political level. And they did this driven by a common passion, and this is obviously a very constructive approach also for our debate today. Our guests today are Giancarlo Cesana, who is ordinary professor at the Milano-Bicocca in Milan, who, well, he has a very long background, but he was also president one of the most famous health care institute, which is the Policlinico in Milano. And then there is Walter Ricciardi, who has already come to the meeting many times in the past, and is the president of the Institute of Health, and he was also president of the Institute for Preemptive Medicine, and he is ordinary professor at the University Cattolica in Rome. Then we have with us Stefania Saccardi, who is municipal councillor for the right to health, welfare, and social and health integration and sport of the region Tuscany. And then, last but not least, as we normally say, Alessandro Solipaca, who has always worked on social aspects and aspects in particularly connected with disabilities, and he is the scientific director of the National Observatory on Health in the University Sacro Cuore of Rome. So I'm going to give him the floor right now, because he will, so to speak, introduce this topic also from the quantitative point of view, so that we can see the different aspects, the positive and the negative aspects of our national health system. And he's got some slides to show us, and he will certainly give us a very interesting overview. Thank you. You've got the floor.
Grazie molto. Innanzitutto.
Thank you. I'd like first of all to thank the organizers of the meeting to speak about a topic which is really important in our country. So during my intervention, I will have to deal with the different themes which are based on the main indicators coming from the official statistics in terms of health of the population, and from different points of view. And then the social and territorial differences we have in our country. So I will refer to some of the fundamental articles of our legal system. So we said that the National Health Service is 40 years, the this year, and it says the Republic safeguards the health as a fundamental right of the individuals and the interests of the entire population. And so this is the first indicator I wanted to show to you. I have, I'm trying to give you an overview of the situation. So this is a life expectancy at birth, and this is one of the main indicators of the health conditions of a population. All the international evaluations start from these data. As you might see, this is a very clear graph, and the outcome of the system, the results reached by the systems are clearly positive. The performance is very good. The life expectancy between 1980 and 2016 has been constantly growing, with a few exceptions, as in 2015. Well, I don't have a pointer, unfortunately, which would have helped. Anyway, the trend is a positive trend. There are just a few fluctuations that are mainly due to the specific circumstances. There are two lines. One is that of males, and the other one is that of females. And well, usually women live longer than men, even though these data are now becoming more and more similar. I don't know whether we can give a positive or a negative reading to this, but anyway, these are the data. And then with reference to the causes of death, over the years, we observed what you can see in these two graphs. Since 1981, there has been a decrease, a substantial decrease in the pathologies of the circulatory system, whereas there has been an increase in cancers and tumors. So there are some some kinds of disease that are decreasing and others that are increasing. I don't want to give you all the reasons why. Then there are experts here with us who will be able to tell you more about these trends. But this is what we see. Then there are other aspects. Another disease is that connected with the psychic problems and the in pathologies of the nervous system. This is a trend that is growing in our country, and I must admit, I must say that some of these pathologies have a dynamic which is linked with the quality of the diagnosis. So maybe these are not phenomena that are linked with the trend of the pathologies. This is mainly how they can be captured by statistics and the ability of the medical world to identify these pathologies. Anyway, they give a clear signal. Then there is a disease in pathologies of the digestive apparatus, and an increase in the number of infectious disease. So now let's move to chronic disease that were identified in surveys on the population. These are data based on self-declarations by the interviewed. So the interviewed declare what their health conditions are. So these are not data coming from archives. And here again, we see interesting trends. There is an increase in diabetes, and there is well, a certain stability apart from the initial fluctuations that maybe are due to an increase in sensitivity towards certain themes. That is to say, pathologies linked with bronchitis and heart pathologies. And as you see also in the graph on the right, you see there is an increase in pathologies linked with pressure, hypertension, and allergies. And all this can be also explained with the aging of the population and the increase in pollution and environmental pollution. And these data have to be taken into account also for the future. Going back to the history of our national health system, I'd like to underline the first two reforms, 502 of 1992 and 517 of 1993. And for the first time, there is mention of levels of assistance. The National Health Plan establishes assistance levels that have to be granted uniformly on the territory, coherently with the financing to the national health system. So there is for the first time a positive list of services that are seen as essential, fundamental by the system itself. And then there is a second reference to the fact that these services that are essential services are financed through funds, the resources that are available for the national health system. So as I was saying, with the reform of 1999, we see that this positive list of essential services is once again referred to, and the National Health Service, it is said, has to be compatible with the financial resources. So we have this positive list of services on the one hand, and we have these financing on the other, which do not depend on the quality of the services, but on the money available. So this is a very important aspect. And here we can see the first trend indicators concerning expenses. So these, the two lines are the public and private expenses, and we have the blue line and the red line, and well, even though they look quite close one to the other, they are not, but they are referred to two different tables. From 95 to 2008, public expenses increased more than the GDP, with an average growth of 6.4%, whereas the GDP had a growth of 4%. Private expenses increased by 4%. So this is a trend that is in a way a parallel trend, so to speak. That means that private expenses do not replace the public system. They both grow, even though the public expenses grow more. One of the characteristics of our system is that it is in a way quite flexible. So it is linked with the increase in the welfare of the citizens. So there is a consumption that grows more. With reference with the second period, 2008 to 2017, so 2008, that is the beginning of the financial crisis, here you can see that there is a clear difference, both in terms of the increase of expenses, which slowed down substantially. So with the reference to the previous years, 0.5%, that is to say less than the GDP, whereas we have an increase in private expenses by 2%. So here, in a way, the private expenses replace public expenses. That is to say that citizens have to intervene privately because there is a decrease in the number of services that are provided by the national system. The Court of Accounts, for instance, shows that the money that is collected through these national health services is decreasing. So this means that are the families, households that have to pay for these services. Let's go back to the law number 833, and we talk about the overcoming the unbalances at regional level, and Article 4. The purpose is to guarantee a uniformity of health conditions throughout the country. So let's go back to the life expectancy graph 2004-2016. So we see again that there is an increase in life expectancy, but as you can see from the graph, there is a clear gap at geographical level. Life expectancy is higher in northern regions and substantially lower in southern regions. This is the map of Italy with reference to life expectancy. As you see, the lowest life expectancy is depicted in red, whereas the highest is depicted in green. And you can see that it's clear that there is a clear difference in terms of life expectancy. And if we go down to the provincial level, in Caserta and Naples, the life expectancy is 8.7 years. In Florence and Monza, it is over 84 years of age. So there is quite a substantial difference. So this graph, which is maybe not so easy to read, well, it shows once again that there are enormous differences in terms of life expectancy, and these discrepancies are actually increasing. All the reasons that the regions that are below the diagonal line are the regions that are substantially below the national average. So as you can see, if you look at the corner on the left below, these are the regions of southern Italy, whereas in the quarter which is on the right on top, you have the regions of the north. So there is this difference which is clear, and it is growing. Another indicator is an indicator of the world indicators concerning the mortality before 70 years of age. So this is how it is distributed in our country. It is higher in the center and in the south, and lower in the north, with the exception of a few regions like Piedmont and Liguria. So this, in a way, shows the inequality that there is in this country. And then let's go back to the to Article 1, where it is stated that the National Health Service is made up of the services for the promotion and maintenance and recovery of the health of all the population without a distinction of individual or social conditions. So the National Health Service, according to this 833 regulation, has as a goal the overcoming of social inequality. Here you can see that there is a difference between men and women, as well as those who have a higher level of education. Here life expectancy is higher than that of people who have a lower level of education. The same is true also for the presence of chronic pathologies. And here again you see these are the data for the period 2005-2013. The differences in terms of level of education are clear, and they are also increasing. Then there is another aspect I wanted to tackle, that is that of access to the health service. You can see here that the data which are concerned to the fact that a citizen decides not to use a public service because the waiting list is too long. So there is this data is higher for those who have lower level of education. Then again, the higher levels of income also have a lower level of organization about these services. And then again, our system has problems, but it is still one of the best in Europe. If we compare it with other countries, according to some specific criteria, Bismarck and Beveridge, and it is second only to Sweden. So the same countries with similar systems have a worse performance than our own. So these are this is actually a graph concerning the populations pyramid 2017-2065. In 2025 we will have an increase in the number of elderly people. So this obviously creates pressure on the system. These are the projections that are used with the prevalence indicators that we have today. In 2028 and 38, there is an increase in the number of people. We will have at least one chronic pathology. And it's a substantial increase. In 2028, there will be about 25 million people with chronic pathologies, and the expenses will be 4 billion euros higher than what we have today. And this in just 10 years. Another issue that I wanted to tackle, this is not only a health problem but also a social problem. We will have a number of people with disabilities that is going to grow in 2028. That is to say, people who cannot take care of themselves. And we will have 700,000 people who are not able to, for instance, cook their own meal or carry out normal activities in daily life. So this again will obviously call for a new solution. So what are future challenges? The sustainability of our health system. So we will have to counter somehow the aging of the population, and we will have to find a way to improve the conditions of elderly people. And then there is another aspect which is very topical today. That is to say, health funds. Well, these are, well, I certainly don't want to express any opinion on this, but it is important to know whether these funds will be complementary rather than funds replacing the funds for public health. In the latter case, they might cause an increase in inequality, the same inequality situation that we have observed up to now. Probably, but it is not clear yet, but we might have an increase in sustainability but also an increase in social inequality. Thank you.
Grazie molto a lei, professor Solipaca.
Thank you very much, Professor Solipaca. You've underlined a series of complex points, yet in a very clear and documented way, and this is useful not only for the debate, for the dialogue today, but also for an in-depth knowledge of all the participants and for the possibility to make choices on the part of those who have the responsibility for such choices. You've also underlined the relationship between the health conditions, social conditions, and the health system. This was a field of research of Professor Cesana, and so I now leave the floor to you for your presentation. Very rapidly.
Aspetta che stanno arrivando, Giancarlo.
Sì, infatti. Ok, molto rapidamente.
So very rapidly, I believe that from the point of view of the perspective of our health system and its usefulness, we have three problems: anthropological, demographic, epidemiological, and one is economic. Let's have a look at the anthropologic problem. 3 points. First of all, life is a mystery, which means that one thing is seen, felt, perceived, experimented, but not owned. So you cannot do whatever you want because you don't possess life. Life has all these features. We didn't provide lives to ourselves, and at a certain point, life will end, as Freud said. So the real new event is life itself. Secondly, health before a right, it is a gift. It is a sort of a dowry which is given to us. I come after. So I may consider myself disabled. I am less able. So you cannot claim for health. And at the same time, as Hippocrates, the founder of medicine in the 4th century before Christ, the first action that the physicians have to carry out is to avoid harming the patients. Healthcare stems from gratuitousness. In the classical period, hospitals did not exist. They were born, they were created during the Christian period in order to treat people suffering from infectious diseases. So it was necessary to have people who knew that the last word on life is not death, but life itself. Hospitals were created because of for the resurrection of Christ. And so even the people with the infectious illnesses were catered for. And then, due to the aging of the population, the prevalence of chronic conditions, we now know that treatments do not heal people. So we have a problem with vicinity, we have a problem with friendship, gratuitousness, and the cases debated recently, Charlie, Alfie, well, I can understand the point of view of people when it comes to insisting on treatments. I know that there is a problem with costs of the persistent vegetative state, but if you cater for somebody for free, you cannot simply say no, because men are not a property of the state or of their own families. You cannot say no. So if the Bambin Gesù Hospital said, I will cater for this child and I will take care of his child, a court cannot say no. Because in this case, you go against charity. And without charity, hospitals would not exist. And the medicine would not have developed. So these are the three key problems. And then there are several issues that have already been touched upon, the problems with demography, globalization, accused by many to be a factor for impoverishment and inequality of the population. But actually, in 1955, the life expectation was 48 years, and it is now 71 years. So since 1970, the average life expectancy has increased by 4 months every year. And this led to a very evident aging of the population, especially in many countries, including Italy. In Italy, the population of all people aged over 65 years is very, very high. And this is closely linked to the onset of some conditions. As for migration, from this point of view, the migration flows will not be enough. According to estimates and according to the data of the last few years, considering migration from Africa, Asia to Europe of 30 million migrants, with these trends, we will have 63 million deaths. This will lead to an increase of the index of structural dependency. So the ratio between the non-active population and those and the active population in 2050, with the fertility levels that we have at present in Italy, and with the aging of a population, for each person working, there will be a person not working. So this is going to be unsustainable. Even more so that pensions in Italy have a cost which is significantly higher than the average in the European Union. We have two problems. Italy is the country with the smallest ratio of people employed, people working. Many people just a few years ago could retire long before they reach the age of 60. And then we have a population which is aging. We have too few young people. And this is no support for the welfare system. And healthcare system is also experiencing a crisis because the costs are becoming more and more unsustainable. As for life expectancy at birth, there has been a slight decrease, probably because of the economic crisis. The life expectancy is not only linked to the healthcare system, of course, but especially to income and living conditions, and it grows with the growth of income. In case there is a decrease in income, there is also a decrease in life expectancy. After 1989, in the Soviet Union, the average life expectancy decreased by 6 years. And only now it is returning to the previous levels. As for aspects related to epidemiology, I will not dwell on these aspects, but what is worth mentioning is that the global burden of diseases, so the extent of the conditions in the world, is constant. It is true that many diseases are corrected and healed, but it is also true that due to the aging of the population, there are lots of chronic conditions. And so from the point of view of costs, the amount of illnesses in the world remains the same. We have a specific problem in the pension system in Italy. 17% of this system is a burden on the GDP, which is higher than the average level of the European Union. In case the Fornero law is abolished, well, this system will become totally unsustainable. So I don't know what will happen. From the point of view of dissemination of diseases, of conditions, in developed countries, especially neurological conditions and pathologies are emerging, especially dementia and depression. The cardiovascular diseases are the main cause of death in the entire Western world, with the exception of Latin America, where the first cause of death is interpersonal violence. As for the comparison between public and private expenditure, in Italy we are at about 9% of GDP. If we have a look at the per capita expense for healthcare system in Italy, when it comes to the OECD, Italy is on the right side of the scheme, so Italy is worsening when it comes to the situation. We are moving towards the situation of Romania, Bulgaria. So the per capita expense in Italy is a little bit more than $3,000, whereas in Germany it is almost is $4,800. In France, $4,400. So we have less resources, too few resources used for a healthcare system. And we have a welfare system by which, at birth, for each child being born, the state pays 8,000 euros. From the point of view of reputation, the Italian healthcare system has quite a good reputation. In the year 2000, the WHO placed Italy, says Italy ranked second after the French system. And this opinion has been confirmed by the American multinational Bloomberg. Because in Italy we have a lot of people aged over 100 years. And one example is Sardinia. Sardinia is the Italian region with the highest ratio of people aged over 100, although it doesn't have the best healthcare system. This is also due, longevity is also due to the living conditions, to genetic reasons. And there is a strong lack of balance between the Italian regions. And so the Euro Health Consumer Index stated that Italy ranks 20th at worldwide. Several years ago, Italy ranked 22nd. So how can we move forward? I would like to mention two sentences by Stiglitz, the Nobel Prize winner for economics in 2001. He said, human mistakes exist in the private sector and in the public sector, but with a difference. The mistakes. So Stiglitz is a follower of Keynes, so he's not a right-wing party. There's a difference. The mistakes of the public sector are paid by all, whereas those of the private sector are paid only by several people, stakeholders, employees, administrators. Well, in Italy, we also paid for the mistakes of the private sector, unfortunately. But that should be the principle. And Stiglitz also said the doctrine-based positions ensuring that the governments are intrinsically inefficient and that redistribution of resources that does not produce but lobbies groups of pressure to its own advantage are false, as they are useless. Governments must intervene when the market is not able to solve the social needs. This is the subsidiary principle. The government should not do what the lowest level can do. At the same way, the doctrinal positions of the left-wing parties demanding for a more, for a wider governmental intervention, and which idealize the government, giving it anthropomorphic characteristics, as it were an individual, a sort of enlightened despot whose mistakes are always caused by reasons outside the government, are equally useless. We have a mixed system, which is not too bad. I think we should cultivate this mixed system, I think, by increasing subsidiarity. And from this point of view, I would like to say that Lombardy, the Lombardy region, when it comes to a healthcare system, Lombardy is an example. The greatest and the best hospitals in Italy are located in Lombardy, and they are often private institutions, private hospitals, according to the principle of subsidiarity. Thank you very much, Giancarlo, for explaining the nature and the grounds of several problems and for this food for thought. Thank you very much. I now leave the floor to Professor Ricciardi, who is in charge of the most important research institute, especially vis-à-vis the choices that have to be made. And so you've experienced directly the responsibility and the system that needs to be governed also from the point of view of knowledge when it comes to health. So you have lots of hints to give us. Thank you very much.
Gli istituti superiori di sanità si chiama così.
What is called the National Institute for Public Health are created when a country becomes a civil country. About 150 countries of the United States have this kind of institutes. We had a conference last year in Rome with the participation of all these countries, because the objective is to give to politicians and decision makers the information necessary to make the right decisions. So, well, there was no need for something like that when Italy was unified in 1970, when there were no antibiotics and the life expectancy was 70 years of age. In 1934, there is the creation of this institute, because there were a lot of people at the time who died, and there was no kind of way to stop malaria. So there were thousands of people dying, adults and children. So in 1935, this institute was created by people who, well, professors like Professor Missiroli, who was particularly devoted to the studies against malaria, for instance, in the Po Valley. Then during the Second World War, the first antibiotic is produced. It is very expensive. It is really precious, and it was actually like gold sold on the black market, and then penicillin became something that could be produced for all Italians, and millions of people were saved. Soon after the Second World War, there were many foreigners who came to Italy to work, and two people came in exchange from Oxford, and Daniel Beauvais from Paris. They came to work in the Italian Institute for Health Care, and they were awarded the Nobel Prize. There was also Enrico Fermi, who founded the laboratory of physics of the institute, but for racial reasons he had to move to Chicago, where we have today the Fermi Lab, which is the most famous laboratory for research in the field of physics. Today there are 2,500 people working in this institute with reference to all the different areas concerning health, and our purpose is to help politicians. The biggest political solution that Italy had to have in terms of life expectancy, but also in terms of richness of the country, because as you might see, when the National Health Service was born in 1978, the number of women that died giving birth was 3 times higher than in Sweden, and 2 times higher, twice higher as in France. In the 1970s, there were 30 children out of 100 dying before they reached their first year of age. Now there are 3 children. So this means that our institute helps politicians to make the right decisions. And what are the most worrying aspects today? That this National Health Service, if we do not intervene, will simply disappear, as it did in other other countries that had to face the economic crisis, which are now in a phase of recovery. Greece is finally out of the bailout after 8 years. Spain, Portugal, all the countries that were saved by the Union, the European Union, have now a GDP which is higher than that of 2008. The only country in the EU which has not yet recovered its economic position is Italy. So why are we worried? And this is something we have also to tell the citizens. We carried out a survey. We asked citizens, what is the National Health Service? Well, there were not so many who knew what it is. And most people did not know that there was this service, and this 40th anniversary was met with quite a great indifference. On December the 4th, there will be a big celebration, but most Italians do not understand that they have this great resource, which is taken for granted, whereas we have to underline that this is a very dangerous thing. The first aspect is the aspect of democracy. We have to have more children. In 1978, the average family was two children for parents, two grandparents. Today we have one child, two parents, four grandparents, and two great-grandparents. So, well, this is not sustainable, because if those who are at the top of this pyramid are ill, they need services, and who pays for these services? So this, well, and I just recall two examples, France and Germany. In France, you can when you have your first child, you have some incentives. For instance, you don't have to pay for kindergarten or crèche, and if you cannot use the public service for your kindergarten, you are given funds. Then you have a substantial fiscal reduction, about 40% for your second child, and you have an even bigger fiscal advantage for the third child. So it's obvious that people make more children, have more babies in France than in Italy. Then there is the epidemiological aspect. 40% of the people in Italy today already have a chronic disease, already have some kind of problem, diabetes, osteoporosis, or other more serious pathologies that call for medical assistance. So what is the challenge here? It is to preempt these pathologies, to avoid these pathologies, and once people fall ill, then obviously they need to be taken care of. So, and here we are really lagging behind. 90% of Italians fall ill for 4 reasons. We eat too much and in a correct way. We do not do sport. We drink too much alcohol, and we smoke. 96% of disease spread in Italy come from these 4 behavioral reasons. So the state has to help its citizens make the right, healthy choices. In Copenhagen, up to 10 years ago, people drove to work. Now only 4% of the people drove to work. Most use public transport, or they cycle, or they walk to work. So they actually make physical activity, even though they do not do sports. And then obviously there is the control on the consumption of alcohol and tobacco, and also our eating habits, also because we have the Mediterranean diet, which should help us. Let's, in particular in the south, in Naples, which is my own city, the boys and girls of the past in Naples were all skinny. Well, now they are all fat, they are all overweight, because they spend all their time in front of the television or in front of their PlayStations and eat too much, and they are well, my colleagues in the hospital Bambin Gesù have a lot of young patients with diabetes. And then there is another aspect which is connected with the national services. So how can we use the extraordinary technologies that we are provided by the research, vaccines, tools for diagnosis, and pharmaceutical tools. So we have so many different resources. So what also the previous speakers said is that these great discoveries actually reach only a few. In Italy at the moment there are big parts of the country, 34 million citizens who do not have those medicines which, for instance, in Germany are always available. And I can actually make a lot of examples. One could be that of regarding osteoporosis. Italy is the only country in the European Union where the pharmaceutical for osteoporosis, which is an injection which has to be done every 6 months, and this is obviously very cost effective for because I can imagine that there are many people here who suffer from osteoporosis. How many of you do this injection? Just a few, because in the other 27 countries of the European Union, the Slovak Republic, Slovenia and so on, it is your general practitioner that actually prescribes this injection to you. Whereas in Italy this does not happen. A woman can actually use this injection only after she had a fracture, a bone fracture. So only after that she can be given this kind of injection. So what happens if a rich person has cancer in the United States? As you know, cancer is not a single disease, but there are different forms of disease. So in the United States, a rich person undergoes a series of tests to identify the best therapy. And this is a figure that has been given to me by Professor Marchetti, who is a great oncologist. He told me that in Italy, 80% of oncologists, because of the organization, prescribe immediately very aggressive chemotherapies which do not give important results, even though they do bring the usual side effects. This is avoided in the United States through these analyses. We, in our institute with Professor De Maria, we have identified some tests which are not expensive but could be useful. Only, well, maybe 20% of oncologists in Italy use these tests. What does this mean? That, as Professor Cesana said, even though we have a good quality in terms of national health service, because, for instance, data are even worse in Great Britain, but we do not, give an assistance of adequate quality. Then there is another problem which is not known at all. Healthcare comes from the people. There are other sectors which can use robots. You know, this is the great challenge. Millions of jobs, the simplest ones, is going to be carried out by robots. We don't know whether by 5 or 10 years, like for instance driving a car. But there is something that cannot be done by a robot. The assistance, the care of people by nurses and doctors. Of course, they can be helped by robots, maybe in the diagnosis phases, but they cannot be replaced. The kind word, the empathy, this cannot be replaced. And so this is in a way our masterpiece, our Italian masterpiece, the inability to find solutions. And I just give you a few data. We produce every year, and I'm talking about doctors, medical doctors, because for other professions and the nurses and so on. We don't have enough. We lack 40,000 nurses. Do you know how many doctors in our medicine faculties, which are all very good in Italy, from Sicily to Trentino? So, how many doctors graduate in Italy every year? About 10,000. So then what happens? Of these 10,000 doctors, mainly educated in public universities, that is to say, in a way, financed through our own taxes, we, every year, we just have 6,000 opportunities in specialization schools. When I started to study medicine, we were 1,500 people, but only about 30% of us graduated. But so from the absence of a planning strategy in the past, today we have 10,000 doctors and 6,000 of them can go on with specific studies. And then about 1,000, they become general practitioners. What happens to the other 3,000? About 2,000 per year go abroad, where they are attracted because they are very well paid. I think this is something that our politicians should take into account. We have asked for this many, many times. It is a joint responsibility of two ministries, the Ministry of Health and the Ministry of Education and University. And I conclude by saying something about citizens, because the other responsibility is that of citizens. As I said, the awareness of having a national service that doesn't ask for your credit card when you enter a hospital, because this is what happens everywhere in the United States, but not only, also in Northern Europe, unless you have your small, your little health card. So, well, our citizens don't know this. I cannot understand how in 2018 no regions, not even the south, there have been protests against this. In Naples, for instance, there was never a protest, a public demonstration on this. In some regions, in emergency areas in the hospitals, there are patients that are followed by doctors who are really working too much, and they cannot be cared of in a right way. So, well, when there were shootings in the past, people were cured with ice. So I'm talking about something that happens in Italy. What does this mean? Citizens have to wake up before we lose our national service. And this is what is happening at the moment. And at the moment in our country, there is already a certain development. You know, we know already that there is a geographical evolution, but there is also an economic and social evolution, because the biggest Italian companies, when they renew their contracts, they include company welfare. After many contracts were renewed after the Monti decree, these contracts were negotiated in order to give some kind of security to the employers of these companies. So, well, they actually safeguard their labor force, their employers and their families. So we are going back to 1888 2008, when the associations of artisans would take care of the health care of their members. So let's wake up, all of us. And in our national policies, we need more than declarations of intent, but we do need practical decisions on, for instance, support to professional training, access to pharmaceutical, and the use of technologies for citizens. And I still remember when we talked about vaccines last year, the only public demonstration in our country is that of the so-called no-vax, those who are against vaccines, and who actually demonstrate not about important things but about irrelevant things which put children's health at risk.
Walter.
Thank you very much, Walter. So, glories, but also miseries. It is important that you've ended your contribution by calling upon us to remember the positive aspects, the lights, rather than the shades. So you mentioned that there were some people who noted that you've made a mistake when you said 4 parents. Well, I was wrong. I wanted to say four grandparents and not 4 parents. So the parents of the parents. So thank you very much for your contribution. In the short conversation we've had before starting this session, I proposed the Councillor Saccardi to be the last speaker. It was a common decision, and it was a decision which results from the logics. The experience of politicians was left but I hope I will not be an example of the lack of power of the politicians. So what happens on the part of those who are in charge of making decisions? Thank you, first of all, for inviting me as the Tuscany region, and I will now promote my region. We have a stand of the Tuscany region in the healthcare sector of this Rimini meeting. So hopefully I can repeat this experience next year, if it's possible. Those who have the responsibility to make decisions, considering the data and the figures you've supplied, well, the decision makers have the very difficult task to ensure, on the one hand, as Professor Solipaca said, the compliance with the Law 833, so the compliance with the levels of healthcare. And as Walter said, they also have the responsibility to ensure innovation from the technological and pharmacological points of view, along with sustainability of the system. And this certainly has to do with the choices based on the organizational features and with the availability of resources. The 4 billion Professor Solipaca mentioned in this situation are not enough. We cannot continue to work with a system with such a low funding vis-à-vis the GDP in a period in which the discovery of innovative drugs and discovery of new techniques and new technologies calls for a review of the systems to cater for the patients One example is that of the drug against the hepatitis C. This drug has radically changed the overall scenario. So hepatitis C will probably be defeated once and for all. So today, when it comes to the funding of the healthcare system, it is necessary to make some reflections, to reflect, and especially considering the topic of equality. We all know that there is a difference between the Italian regions, and this denies the universal right to health, which is enshrined in the Italian constitution. This calls upon the national government to take a greater responsibility, but it also refers to a wider reflection in comparison to the one I witnessed in the committee when it comes to the subdivision of the funds for the healthcare. The response is not, the answer is not you need to give me more money because I am weaker. The system is you need to give me, to help me in order to remove the causes of the situation. Otherwise, we confuse the causes with the effects. If we limit ourselves to simply focusing on the subdivision of the funds for the healthcare system, we run the risk of impoverishing the regions, which, taken individually, could guarantee one of the best healthcare systems in the world, namely the Italian healthcare system, especially when it comes to the funding of the system. Epidemiology certainly changes, and we run the risk of transforming a positive aspect, namely the growth, the increase in the life expectancy, into a negative factor. So if life expectancy increases, the chronic illnesses also grow as a consequence. The disabilities and the non-self-sufficiency situations also increase. But we must not forget that the increase in the age and life expectancy is always a positive factor, which certainly is due to our healthcare system, but health is not limited to the healthcare. Healthcare probably accounts for only 20% of the policies related to the health of the citizens. As you said, Walter, health has to do with economic situations, social conditions of a population. It has to do with the environment, with the habits, and probably the common feeling of a population. But certainly, a healthcare system must be equipped to face future challenges. So how can we face all these challenges? On the one hand, we must work on prevention, so trying to avoid the onset of illnesses, so trying to have a population which gets sick less than in the past. This means investing seriously in prevention, in preventive measures, not only with the campaigns on the healthy lifestyles. I also insisted to have the responsibility for sports. You know that decision makers see the powers related to sports as a sort of a Cinderella kind of power, of responsibility. But sports is closely linked to the healthcare and to the health of a population. If you identify sports with physical exercise in general and the dissemination of correct habits and values. I've seen that the meeting has a very interesting and very wide sports area in collaboration with the CSI in Tuscany. So we should also continue to foster vaccination. I am shocked by the level of the debate I've been witnessing over the past few days. I want to excuse those who still need to understand that when you govern, you need to make decisions, and you need to take on the responsibility for the decisions you've made, and you must decide for all the population. You do not simply exert a power, you take on a responsibility vis-à-vis the interests of the entire population. When I hear the Minister of the Interiors telling that 10 vaccines are too much, maybe the proper number is 6. As far as I am concerned, the physicians and the experts will decide on the minimum amount of vaccines to be given to the children. This is not a task of decision makers. Decision makers need to take on the responsibility to say that in a moment in which the country runs the risk of becoming a place where it is difficult and dangerous to arrive, because in the other countries, everybody's saying, get vaccines before you go to Italy. The decision makers need to take on the responsibility to take a stand, and state what they stand for. They should not simply limit themselves to postpone decisions. They need to make decisions. We, as Tuscany region, will continue to not to postpone and not to resort to this self-certification when it comes to vaccines for the students, for the pupils. Another topic on which we should try and reorganize our services is the issue related to chronic conditions. Through the drafting, while we're drafting the new integrated health and social plan, we are focusing on these aspects. A big issue is that of catering, taking care of the people. We should focus on what we mean by taking care of a person 360 degrees. It means strengthening the role of the territory. First of all, chronic conditions are faced in the territory, not in the hospitals. Otherwise, you provide an expensive and unsuitable response. It means that you need to be able, we've called these facilities health societies, and we try to carry out integration, and all subjects, starting from the general practitioner, should start to cater for the people with a privileged relationship with the hospitals, without passing through the emergency room, so a sort of connection between the GP and the hospitals with the specialist intervention in case of complex cases. So the hospital becomes an open place, and there is an interaction between the GPs and the hospitals. There's a group of professionals available, and you can connect with them. And this means solving the problem of urgent procedures or urgent healthcare with fast track. It means having a very strong connections, and it means having the family or community nurse, and the Tuscany region is the first Italian region to invest in this respect. What do I mean by catering for the patients and for the people? It means accepting the challenge of taking care of a person even when we cannot heal or treat the person. We should cater for the person. We should not identify the person only with the condition. if we only focus on the conditions, on the diseases, well, then you should not be surprised of the fact that the physician in the end will be Dr. Google and not the real specialists, not the real physicians. Catering for a person means catering for a person until his or her last second. We should focus on the provisions patients live in case they are in a condition which cannot be treated. Today is the anniversary of the death of Father Paolo Bargigia, and he gave us an extraordinary example. Well, I come from Florence, and he provided a very precious testimony when it comes to how you live, how you experience disease. So catering for the people, catering for the patients, does not simply mean connecting the hospitals and the territory, but also vice versa. So moving from the territory to the hospital and vice versa. We've created the continuity agencies between the community and the territory, and they are functioning pretty well. So the person upon hospital discharge will not be abandoned. And we tend to focus more and more on the acute conditions. Hospitalization times are getting shorter and shorter. When I was a councillor for the municipality of Florence for community policies, I received phone calls by people asking me to have their family members discharged. I now receive the opposite kind of phone calls, because as soon as a person is discharged from the hospital, well, the family members do not know how to cater, how to deal with this person after hospital discharge. So we need to provide services after a patient is discharged from the hospital. I would like to say something more before I conclude. I share Professor Ricciardi's view when it comes to a short-sighted politics when it comes to the professionals. We want to stress this as regional representatives, and I'm not referring to the political beliefs. We are experiencing lots of difficulties if there is no agreement between the Ministry for University and Research, the Ministry for Education, the Ministry for Health. If there is no agreement, we will be forced to hire physicians from abroad, from foreign countries. And these people would be paid with the health funds. Some regions, some of the Italian regions, well, we in Tuscany did it by funding extra grants in addition to those for the specialization envisaged by the ministry, in order to face the lack of physicians, the shortfall of physicians that we have. And this is a guarantee for health care in the entire territory. If I need pediatricians and if I lack pediatricians, I cannot cater for all the kids living in Tuscany. If I don't have an amount of specialists able to guarantee assistance all over the territory, the most remote areas of a region will be penalized, will be jeopardized, because of course the physicians are less willing to go and work and live in the remote areas. But we should bear in mind that we need to guarantee equality in all the areas of a region. And I think we should also reflect on a stronger integration between social and healthcare policies. We have a fund for those who are not self-sufficient in this country, in Italy, which was stabilized about 3 years ago, I think, and it consists of 400 or 500 million euros per year, most of all for the most serious conditions. But this is not a topic, this is not an issue which must be confined to the social sphere. The funds currently available, are not enough. It should become part of the healthcare policies. And I've said this to the minister. Today, the ministries also need to reorganize themselves, and the lack of self-sufficiency should become an important part of the battles of the ministry for health. Otherwise, we allocate resources, the wrong resources, to solve a problem. We cannot face the problem if we continue to live a sort of a Cinderella, which is the whole set of social policies. It is also clear that if we are not able to manage a problem at home, well, then this problem becomes a health care-related problem, because you run the risk of having to go to the emergency room in all cases. And we cannot increase the number of emergency rooms every year. So emergency rooms must not become airports. If you have a look at the accesses and the appropriateness of the accesses to the emergency room, you can find you can find out that 70% of people get to the emergency room on their own without being brought by an ambulance. Not to mention the less severe codes of the emergency room. So social policies must become an integrated part of healthcare-related policies. It makes sense that catering for a patient means having nurses, but also social workers, physicians, the intervention of municipal administration, so a level of home assistance, home care, we are experiencing thanks to the funds of the European Social Fund. So the catering for a person on the part of a multidisciplinary team, so that as soon as this person is discharged from the hospital, you have a general practitioner, specialist, the a physiotherapist, but also the social worker, the basic assistants, etc. I would like to draw to a close by mentioning subsidiarity. I believe that subsidiarity is one of the most important principles which also guarantees the sustainability of our system. I believe that the topic should be tackled with no ideology. Without the volunteers in Tuscany, we wouldn't be able to continue guaranteeing social services and a part of the healthcare system. This is a topic which is being debated during ideological debates. Each time I talk about the so-called social private sector, I'm always attacked by some parties, and they do not consider that today the biggest work contracts envisaged for the integrated healthcare for certain categories of workers. One of the first contracts envisaging for the integrated healthcare system was one of the meta mechanics in the Nuove Opinioni signed by Mr. Landini, who was a secretary of the meta mechanics trade unions. So unless we stop reasoning in ideological terms and we focus on the richness of the collaboration with a certain type of world, bearing in mind that the decision makers take into account the responsibility of planning and control, and this needs to remain in the hands of the public sector, or we run the risk of having a world, a part of our territory, which arranges things on its own. I believe that when a certain things start to be accomplished, the policymakers can either pretend it does not exist, or they can try to take on the responsibility to govern what's happening. This means that with no particular ideologies, we should start to reason in order to understand how all these elements can be contained into a system which must guarantee to all, and I repeat it, to all. This is the value of our system. This is the main feature of the healthcare system in Italy. Whatever your religion, whatever your ethnicity, whatever your choices, whatever your gender, race, origin, or passport, health is a right. Within this boundary of a government, of a governance which is strong on the part of the public sector, I do not share the idea that a citizen should be given a check and then you simply tell citizens, well, now you need to provide for yourself. This is not my idea. This is not my idea of aid or my idea of subsidiarity to keep the third sector within the system. I am against this idea of income based on the citizenship. Not because I don't want to have any solidarity. I've always worked in the social policies. Because I believe that the principle of aid and solidarity cannot be detached from the responsibility of an individual. And I think that this system of assistance, simply assisting citizens, is not only unfair, but it is also unsustainable and unaffordable. So I believe that the debate today on subsidiarity and the integration between the public and the private sector, especially in my region, I believe this is a topic that has to be faced in the proper way by decision makers, reaffirming the role of the public sector. There are certain principles which should be firm and should remain firm, but we should certainly open up a discussion on several aspects. Otherwise, we will not be able to provide an exhaustive response to the challenges we are confronted with. Thank you very much.
Thank you, Councillor Saccardi, for these considerations. And I'd say that maybe there are just a few nuances of differences in terms of possible solutions, for instance, but I do believe that there is a general belief that a national health service is a great resource for our country, a resource for our society, and also a tool for our development for the future, and we cannot afford to neglect it. On my part, I'd like to very briefly summarize three elements that emerge from all the speeches, which are, in a way, cultural aspects of mentality and which need to be recovered in order to be able to use the National Health Service we have. So 3 very quick points. The first thing is to find back the idea of common good. I believe that in many choices, in the health sector, well, health is in a way a personal experience, whereas the health service is a common good to which, as law states, needed to contribute all those who have the characteristics and the resources to do so. So the system of all these different actors, difference in their nature, this system needs to have a single common plan, project. That is to say, it has to be a system that acquires, so to speak, or pursues a common goal for the whole of society. So we are talking about the possibility to satisfy everybody's needs. Then my second point, very briefly, and I refer to what you were saying during your intervention, that is to say, the very futile way by which the public-private dichotomy is tackled. This issue has to be approached in a completely different way, because if we talk about a public service, this does not mean that what is managed by a public administration provides a regulated service. On the other hand, we have to admit that what is not part of the public administration, that is to say, what is private, cannot provide a good service. So these are two different actors who have to follow the same rules, and obviously these rules need to be respected. I mentioned the first article of the reform at the beginning because I think that it is important to make reference to the diversity of all these actors, but it has to be clear that there is a common goal, and I'm thinking about a common goal which is a common good for society. And achieving, or rather pursuing these goals obviously means respecting certain rules. Then, the third point, which is also in a way a cultural aspect, is the fact that it is not possible to separate the individual from the community. Well, everyone says that the individual person is at the center, but this statement needs to be read in its real meaning, and I would like to thank Giancarlo for sharing his thoughts with us. So the person as someone who has health problems, not a standard user, but there is also someone else who cannot be seen as a standard user within this system. That is to say, those who work in this system. Because in my personal experience, but I do believe that my experience is quite common, and you were saying the same thing, these people are the real engine of the service. So it is important to take into account the needs of the patients, as well as the need of the operators, of those who work in the health service, because these people are in themselves a community of prevention, of care, of health promotion, and we made reference to the great, enormous technical, scientific progress. So there are people who are actually managing these technologies. They cannot be applied, so to speak, automatically to the good people, because there are different people, persons are different, and there are different situations. So, well, it is fundamental that there is a clear relationship between the operator and the patient or the user of the service in order to use these extraordinary tools we have at best to acknowledge this connection between community and the single individual is part of the reasoning that if we want to promote, defend, and support human health, we have to take into account all the aspects of our social life, work, family, and so on. So this is quite a big effort that awaits those who deal with health care in our country. Anyway, I do believe it is also an effort that is justified by the search for a common good in the most, so to speak, noble meaning of this expression. So I would like to thank all the speakers for their very clear and interesting contributions. And before closing and letting you go to the many other events of the Rimini meeting, I'd like to remind you all, and obviously I'm sure that you have already heard this many times in these days, that one of the aspects that make the Rimini meeting unique is that it is completely free. All the parking lots, the activities organized for the young, and all this is for free for visitors here, but also for those who follow us from everywhere in the world. So this is because this event is the outcome of the contribution of each of us, volunteers, speakers, the curators of exhibitions, and the visitors themselves. Everyone contributes with something to the meeting: money, talent, energy. So, well, the conclusion, which is, let's so to say, quite obvious, so is that you can contribute to the organization of a meeting by making a small donation. You've seen them around on the grounds. There are the desks with the writing Dona Ora with a red heart. And please donate only at these desks where the volunteers wear a pink T-shirt with the same writing, Dona Ora. So I'd like to thank you all for your time, and thanks to others.